Last week I attended the British Association of Sclerotherapists annual conference in Basingstoke. This meeting reviews the latest developments in venous disease and leg vein treatment. 7 of the main areas of controversy were reviewed, and in this video I'll discuss them with you. The first controversy was, should ultrasound guided foam sclerotherapy be first choice in the treatment of varicose veins? Now, as I've stated in previous blogs, surgery such as stripping under general anaesthetic is no longer appropriate for varicose veins. The National Institute for Health and Care Excellence has recognised this and has indicated that surgery is now third choice for varicose veins. NICE has in fact recommended that endothermal ablation is first choice and that ultrasound guided foam sclerotherapy is second choice. Many at the BAS meeting in Basingstoke felt that this is an unfair assessment. At the meeting, Dr Patricia Pavei, a phlebologist from Italy, discussed the indications for foam sclerotherapy. In her opinion, sclerotherapy is first choice for an impressive list of situations, including recurrent varicose veins, small saphenous vein reflux, non-saphenous veins, perforator veins, residual veins, and great saphenous veins less than 8 mm in diameter. Now, although endothermal ablation is suitable for saphenous veins that are relatively straight, i.e. they're not tortuous, it is clear that sclerotherapy is far more versatile. Nearly any vein in the leg can be treated, and in this respect, many specialists believe that ultrasound-guided foam sclerotherapy should at least be joint first choice in the treatment of varicose veins. Now, the second area of controversy is, how should ultrasound-guided foam sclerotherapy be performed? Dr Philip Coleridge Smith provided a live demonstration of varicose vein treatment at the meeting. He emphasised the need to treat saphenous vein reflux, all the tributaries and all the varicose veins all together, usually in one treatment session. He showed how he places multiple cannulas before administering the sclerosant. His aim is to obliterate all reflux and visible veins. And as part of his protocol, he sees patients 2 weeks later, he aspirates any retained thrombus or coagulum, and he retreats any veins that are still persistent or which are refluxing. Once he's eradicated all the reflux and visible veins, he sees patients 6 months after treatment, and any signs of reflux or persistent varicose veins are once again retreated. His protocol gives excellent results that are very comparable to endothermal treatments. Now, the third area of controversy is, do all patients with leg telangiectasias, that's thread veins, do they need a duplex ultrasound scan? Well, once again at the meeting, Dr Pavei addressed this issue. She provided a lot of evidence, and in her opinion, duplex ultrasound scan is mandatory prior to treating leg thread veins. She pointed out that at least 25% of patients with leg telangiectasia have saphenous vein reflux. Now, not all specialists at the meeting agreed. Many use duplex ultrasound selectively, and they would request a scan in some patients after a careful clinical assessment, perhaps also with a handheld Doppler examination. However, it was acknowledged that the trend is for more and more specialists to regard a full colour duplex ultrasound scan as an essential assessment prior to leg thread vein treatment. The fourth area of controversy is, when should compression stockings be advised after sclerotherapy? Dr. Martyn King tackled this difficult subject with a thorough review of the medical literature, and he led a lively debate on the subject. My own impression is that wearing compression certainly offers benefit to patients after ultrasound guided foam sclerotherapy, and perhaps it offers less benefit to patients after sclerotherapy for thread veins. At the VeinCare Centre, we advise compression after sclerotherapy, but we suggest that if the compression is uncomfortable or causing problems, that it is immediately discontinued. It was acknowledged at the meeting that many specialists do not prescribe compression stockings after thread vein injections. Now, controversy number 5 was, do all patients with phlebitis need a duplex scan? Dr. Rangarajan, a consultant haematologist from Basingstoke, gave a thorough review of deep vein thrombosis and phlebitis. From her presentation, it was clear to me that patients with phlebitis do have clots in the superficial veins and that they are in a hypercoagulable state. That is, they have sticky blood. As many as 25% of patients with phlebitis have a coexisting deep vein thrombosis, and many of the remainder are at high risk of developing a deep vein thrombosis. It is my opinion, having listened to Dr. Rangarajan, that everyone with phlebitis should have a duplex ultrasound scan. Now, the 6th area of controversy was, can complications of sclerotherapy be avoided? Dr. Philip Coleridge Smith gave a wonderfully illustrated review of complications associated with sclerotherapy, many based on his role as a medical expert in cases of complaint and litigation. Based on his presentation, it appears that a majority of serious complications following sclerotherapy can be avoided by careful technique, slow injection of small volumes of sclerosant, and by using the correct dose and strength of sclerosant. Now, controversy number 7 was, what is the best treatment for leg thread veins? This proved to be the least controversial area. Live demonstrations of leg thread vein treatment by Claire Judge and Julie Halford, as well as discussions led by Dr. Pavei, Dr. Stephen Tristram, Dr. Martyn King and Philip Coleridge Smith, confirmed that microsclerotherapy, carefully performed after a thorough assessment, which in my opinion should also include a duplex ultrasound scan, certainly gives the best results. Well, I hope you have found this video interesting. Do please remember to subscribe, and that way you will be the first to see my next video on leg health and venous disease. My name is Dr. Rangarajan. Thank you for watching.